In a dim chamber of Richmond Palace, winter pressing against the leaded windows, the Virgin Queen stood like a portrait come to life. Only this portrait trembled. Her silks were dark, her hood drawn low. The powder that had for decades smoothed the lines of state now sat thick and pale on skin that had lost its firmness. Courtiers who had once watched her command parliaments and stage royal pageants now recorded a smaller, more fragile presence. A sovereign who would sometimes remain for hours, motionless by an unlit hearth, refusing to sleep, refusing to eat. The question that shadowed every quiet corridor and every whispered counsel in those last weeks was simple and terrible. With so many possible causes, what really happened at Elizabeth I's death? Elizabeth Tudor died on 24 March 1603, and yet the scene of her decline, slow, mysterious, and intensely personal, has continued to invite speculation. The monarch who had reigned since 1558, who held England through religious settlement, maritime expansion, and the Armada's defeat, left no heir and no explicit medical account. What survives are fragments, letters, ambassadorial dispatches, notes by attendants and counselors, and later recollections that often strain at the border between observation and legend. Interpreting those fragments requires care, an ear for what contemporaries saw and what they imagined, and a steady refusal to translate rumor into medical certainty. To understand the end, we must first see the whole that preceded it. Elizabeth's 44-year reign had been an exercise in controlled spectacle. She cultivated an image of chastity, of virgin sovereignty, of a monarch who transcended gender. Her portraits, her speeches, the jubilee theatrics of her court were all carefully wrought performance. That performance relied on costume and cosmetics, wigs and patches, pearls and veils, and a white facial paint, Venetian ceruse, favored across elite Europe. The crown was both a persona and a burden. It required continual maintenance of an illusion that sometimes masked private grief. The single most vivid personal rupture of Elizabeth's later life was the fall and execution of Robert Devereux, 2nd Earl of Essex. Once a charismatic favorite, Essex's rebellion in 1601 ended at the scaffold, and his fate left a wound in court life and, by many accounts, in the Queen herself. Witnesses in the months that followed reported a sovereign whose public gaiety had become brittle. Those who had seen her weep described a grief that did not merely follow political calculation, but bore the weight of attachment and the taste of betrayed expectations. Tudor ideas of mind and body treated such sorrow as an ailment in its own right, melancholia, a humoral imbalance, and contemporarily read emotional disturbance as both cause and symptom of physical decline. Modern toxicology shows that chronic lead exposure can produce a variety of neurological and systemic symptoms: cognitive clouding, tremors, gastrointestinal distress, kidney problems, and discoloration of teeth and gums. In the case of Elizabeth, the imagery of a pale, heavily powdered face that persisted into old age invites a question. Could prolonged cosmetic practices have contributed to a slow poisoning? There is supportive detail. The Queen's teeth were repeatedly described as blackened and unsightly. Lead can cause a blue-black line on the gums and accelerate dental decay in certain contexts. Attendants reported tremors and diminished vitality, features that align, in a general sense, with chronic lead effects. Yet, the counter-arguments are immediate. Many of Elizabeth's symptoms, shortness of breath, feverish episodes, and an acute decline in early 1603, suggest an infective process that does not map neatly onto chronic lead toxicity. Lead poisoning generally runs a more protracted and insidious course, producing a complex of cognitive and abdominal symptoms less emphasized in the complaint lists of the time. Furthermore, the use of ceruse was widespread among the aristocracy. If lead exposure through cosmetics were rapidly fatal, courts across Europe would have seen a different pattern. In short, lead exposure from Venetian ceruse is a plausible contributing factor, especially as a chronic stressor on the Queen's body, But there is insufficient direct evidence to elevate it from hypothesis to cause. Plausibility, medium. Justification, cosmetic lead exposure could explain certain chronic signs, but not the acute episodes recorded in the closing weeks. Another line of speculation reaches for the most common mortal enemy of the pre-modern world, acute respiratory infection. Physicians and household records note that Elizabeth suffered colds that worsened into deeper coughing fits, and eyewitnesses described her growing weaker after a winter of poor appetite and sleeplessness. Pneumonia in its various bacterial or viral guises can lead to fever, productive or dry cough, progressive weakness, and death, particularly in an elderly person whose nutrition and sleep are compromised. The winter of 1602 to 1603 was harsh. Exposure to cold and the stresses of court life would have made an older body vulnerable. Support for a pneumonia hypothesis appears in the sequence of events recorded by those at Richmond. The Queen's cough, her loss of strength, and a final collapse consistent with respiratory failure have the texture of a chest infection taken to its lethal extreme. Yet, contemporary observers did not uniformly record the high fevers or the characteristic rales a modern clinician might expect. And the detailed emphasis on dental disease and skin lesions pushes some researchers to consider an alternative primary pathology. Pneumonia remains a credible proximate cause, especially given the combination of age and frailty, but it fails to account for the broader, long-developing physical decline by itself. Plausibility, high for an acute terminal event, medium as the sole explanation for the entire decline. Dental disease and the specter of septicemia, or systemic blood infection, form a third thread. Elizabeth's teeth were in poor condition. Tooth decay and abscesses were common in an age without dental surgery as we know it. A festered dental infection can breach barriers, seeding bacteria into the bloodstream and producing a septic illness. Accounts noting mouth and gum problems, the presence of sores, and a final rapid physical deterioration invite the hypothesis that an oral infection progressed to systemic sepsis, hastening death. Evidence in favor includes attested chronic dental trouble and contemporaries' observations of swelling or pain in the mouth and face among elites of the time. Counter-evidence stems from the lack of explicit mention of pus-draining abscesses or the kind of high fevers that classical sepsis produces. Yet it must be remembered that early modern physicians described syndromes differently. Fever could be downplayed in some reports as weakness or coldness. Septicemia is therefore plausible, perhaps as an immediate mechanism by which the Queen's life ended, while not necessarily explaining the slow months of decline. Plausibility, medium to high as an immediate terminal mechanism, depending on how one reads the fever descriptions. Finally, the mental and emotional dimension, often labeled in Tudor medicine as melancholia, cannot be separated from the physical record. Melancholia was not simply sadness. It was a humoral imbalance associated with black bile, thought to produce listlessness, insomnia, appetite change, morbid brooding, and, in advanced cases, physical decline. Many contemporaries explicitly read Elizabeth's comportment through this lens. Her refusal to eat, her long hours of standing, and her periods of muteness were all interpreted as outward signs of inward desolation. The execution of Essex provided a potent narrative to justify such readings, a sovereign who had invested emotion in a favorite, now bereft and racked by guilt and regret. Modern readers must be cautious here. Melancholia as a category does not map neatly onto modern nosology. It could include depression, complicated grief, or neurovegetative symptoms of illnesses like hypothyroidism or chronic infection. Nonetheless, the behavioral features recorded, withdrawal, loss of appetite, disrupted sleep, reduced interest in customary pleasures, are consistent with a depressive syndrome that could very well have worsened physiological resilience. Such psychological collapse could also have impacted the Queen's willingness to accept or comply with medical interventions, worsening outcomes. Plausibility, high as a contributing factor to decline and a modifier of disease course. These four strands, cosmetic lead exposure, acute respiratory infection, septic complications from dental disease, and a melancholic collapse, do not exclude one another. Indeed, the most historically coherent reading treats them as interwoven. Chronic stressors and exposure, including possible lead, set the stage for frailty. Emotional devastation after Essex undermined appetite and sleep. Dental disease created a nidus for infection, and an acute respiratory or septic event delivered the final blow. Historians who emphasize multi-causality argue for precisely this sort of braided explanation. Yet to assert that with certainty would be to go beyond what the sources can sustain. The available testimony points to a woman who was both celebrated for her public mastery and secretly vulnerable, whose body, long cosmetically masked and politically armored, finally yielded. While medical theories circulate, politics moved with a quieter, more calculating tempo. Elizabeth's refusal to name an heir was not merely a stubborn refusal, but also a strategic avoidance. A named successor might have invited factional violence and the possibility of undermining her sovereignty in life. The absence of a living Tudor heir left England perched precariously on the issue of dynastic continuity. Robert Cecil, Secretary of State, practitioner of shadow diplomacy, and historically credited with much of the eventual smoothness of the succession, was already making discreet inquiries. Courtiers worried not simply about who would reign, but how to secure the crown with minimal tumult. The context sharpened the human drama. A queen who had maintained the spectacle of timeless rule now faced the very human, pressing realities of age and decline in a polity that required certainty. Courtiers talked in corridors. Messengers were poised to ride to Scotland. Ambassadors in London, sensing the Queen's vulnerability, dialed up their reports to Madrid and Paris. Their dispatches often read like temperature-taking instruments, noting the Queen's diminished appetite, her long vigils, the hush that had settled over court entertainments. London itself braced for the news of change. For some, the prospect of James VI of Scotland ascending a united throne promised stability. For others, it risked the end of the Tudor experiment and the beginning of a new, uncertain Anglo-Scottish era. In that winter and the cusp of early spring, the visual markers of Elizabeth's reign assumed a melancholic hue. The crown's pageantry, so carefully staged, took on the sense of a requiem. Portraits of the Queen, already showing the signs of aging under layers of paint and powder, became documents of a monarch's last performed self. The cosmetic mask, the white face, and pearl ornaments read differently now. Not merely the sign of sovereignty, but possibly the final veil of an ailing body. Several contemporary observers recorded moments that crystallized the court's dread. A lady of the household, her name appears in some lists of attendance but remains uncertain in some transcriptions, wrote of the Queen's silence and refusal to take food, and an ambassador noted that Elizabeth, who had once feasted with gusto, now sampled only a few mouthfuls. Within the Privy Chamber, councillors began to weigh the legal and practical steps that would be required once the inevitable came. Robert Cecil, known for his capacity to work behind the scenes, positioned himself to act decisively. He had contacts at James's court and an organizational ability that made him the likely steward of transition. Yet none of the mechanics of succession could alter the fact that the sovereign herself remained the center of a human tragedy. As March progressed, the Queen's condition moved from worrying to critical in the eyes of those around her. The household physicians, schooled in Galenic regimens, attended and administered what they could: bloodletting, purgatives, expectorants, aromatic therapies intended to rebalance humors. Some of these treatments might have provided transient relief. Others, by modern standards, were ineffective or even harmful. Their limitations underlined a broader truth about early modern medicine. Skilled practitioners worked with frameworks that mixed observation and tradition, but they lacked antibiotics, reliable surgical interventions, and the ability to test for systemic infection. Against the steady advance of whatever physiological process was at work, the available therapies were often inadequate. In the small hours of a late winter morning, reports differ on precise timing, as they often do in these human scenes, the Queen was found wan and weaker than ever, her flesh thinner beneath the royal robes. Attendants gathered. Those who had long served her spoke of a dignity that remained, even as strength failed. At some point near the end, a hand, sometimes said to be that of a lady-in-waiting, covered her face, a gesture recorded by more than one witness, and the chamber sank into a hush that was almost an act of worship. The moment of passing itself, insofar as it can be reconstructed, was both private and profoundly consequential, a singular human death that would instantaneously reshape the political life of a nation. But before we move from the scene to its aftershocks, before we catalogue the Council's immediate measures, the dispatch of agents to Scotland, and the public rituals that would frame the Queen's body and crown, there are questions that remain stubbornly open. Which of the medical threads was decisive? How much did prolonged emotional strain weaken physiologic resistance? To what extent did habitual cosmetics play a toxic role? Were dental sepsis and pneumonia twin forces converging in the final days, or was one the primary engine of decline? Part of the difficulty in answering these questions is the very nature of the sources. They are testimony recorded under stress, filtered through political aims, and sometimes refracted by later myth-making. What we can say with confidence is this. In the months before her death, Elizabeth displayed a combination of chronic and acute symptoms. Her emotional life had been deeply marked by personal losses that contemporaries associated with melancholy. The medical interventions available to her were limited, and the court's political actors, above all Robert Cecil, were already preparing for the constitutional vacuum her death would create. The Queen's body, performed for decades as the living emblem of state, finally showed cracks that neither powders nor language of sovereign power could conceal. As rumor thickened into reporting and reporting into action, messages were hurried to Scotland. A network of couriers and confidants moved with the nervous efficiency of men who knew that speed might prevent chaos. James VI, the aging king of the Scots, received word in stages. The news carried by a series of messengers who would, within days, find themselves at the center of a transfer of crowns that had been, for years, only the vaguest of possibilities. The machinery of succession, letters patent, private alliances, the watchful eyes of Europeans abroad, began to click into place even as physicians inside the palace continued to measure a failing pulse. Inside Richmond, the Queen's attendants kept vigil, some recording details that later chroniclers would seize upon. A cough that would not abate, hands that shook, the primitive remedies administered at bedside. Outside the palace, the city held its breath, both anxious for the order that could follow a peaceful succession and fearful of the disorder that could follow a contested one. The overlapping anxieties, medical, emotional, and political, made Elizabeth's death more than the passing of a monarch. It was a hinge between eras. It is at this juncture, the Queen's body diminished, the physicians uncertain, and the ministers poised to move, that our narrative arrives at a threshold. The threads of illness and policy intertwine here in ways that reward close, separate attention. The medical hypotheses, rich with supporting observations and equal measures of doubt, insist on careful comparison. The political responses, staged precisely to limit turmoil, demand scrutiny for motive and method. To understand what really happened at Elizabeth's death, we must hold both strands in view. The intimate bodily decline of a woman who had long been a public emblem, and the clinical, often bureaucratic processes by which a realm prepares for the passage of power. As the court's murmurs turned to plans, as riders set out for distant houses and for the Scottish court, the Queen in her final chamber remained. To those who loved and to those who served her, an image of complex majesty. Still Queen, still the object of ritual, yet now unmistakably mortal. The next steps, how the physicians' diagnoses would be interpreted, how the counselors would coordinate, how the funeral rites would be arranged, follow from this liminal hour. Each decision averted or taken would shape not only the immediate succession, but how posterity would frame the last days of the Tudor age, and how historians centuries later would weigh the balance between ailment and allegory. If this story is pulling you in and you enjoy deep dives into history, please like and subscribe. There's more long-form work like this coming. The months after the Queen's quiet passing moved like the closing of a book, with many hands at work on the binding. Inside the palace, the immediate practicalities folded into ritual. The bedchamber was cleared, physicians in attendance signed their names to statements that would later be copied into official records. The silver and jewels of household inventories were sealed and counted. Outside, the machinery of state adjusted with a combination of haste and care. Men with experience in administration, Robert Cecil foremost among them, did what they had long rehearsed in private. They shored up the government, secured loyalty in key places, and smoothed the path for a peaceful dynastic transition. These were administrative acts, but they took place against the opaque backdrop of a single human body that had once been both mask and model for monarchy. To understand the final sickness in fuller detail, it helps to place the individual threads in the orderly fashion of comparative forensics. We have already sketched the main candidates: chronic lead exposure from cosmetics, acute respiratory infection, pneumonia, systemic infection arising from dental disease, septicemia, and a profound melancholia, and suggested that none alone completely explains the evidence. We now unpack each in a fuller, more clinical register: what modern medicine means by the term, what the contemporary sources tell us that might confirm it, what they do not, and how historians evaluate its likelihood. Old age and generalized physiological decline is the most prosaic and yet often the most powerful explanation. In modern terms, this is not a discrete diagnosis, but a description of diminished organ reserve, the gradual loss of the body's capacity to respond to stressors, such as infection, malnutrition, or trauma. At the time of her death, Elizabeth was 69 by the New Style dating, born 7 September 1533. In an age when even the relatively privileged seldom survive to this age, the accumulation of decades would have left her vulnerable. Primary evidence for this interpretation is straightforward. Observers repeatedly note weight loss, frailty, decreased stamina, and impaired sleep, classic signs of age-related decline. Her ability to withstand a respiratory infection or to recover from a systemic insult would have been greatly reduced. This explanation's strength is its simplicity and compatibility with every other account. Age does not exclude other causes, it amplifies their effects. Its weakness is its generality. While it accounts for susceptibility, it does not identify a proximate lethal mechanism. Plausibility, high as an enabling factor, medium as an exclusive explanation. Pneumonia, the acute infection of the lungs, holds pride of place among scholars who prioritize the immediate cause of death. In contemporary terms, chronic coughs and bouts of a cold could evolve into a more serious pulmonary infection. Modern physicians would point to a pattern many witnesses observed: a winter of worsening cough, progressive weakness, a decline in oral intake, and a final rapid deterioration. Pneumonia is known to be particularly dangerous to elderly, malnourished, or sleep-deprived patients. It can lead within days to respiratory failure or sepsis. Support for a pneumonia hypothesis includes the repeated references by household members and foreign envoys to increasing cough and breathlessness. The speed of decline in March 1603, moving from pronounced weakness to incapacity over a short span, fits the model of an acute chest infection superimposed on frailty. The main counter-argument, however, is absence of richly detailed febrile descriptions in surviving narratives. Many reports emphasize weakness and pallor rather than high fevers, or the rattling chest sounds a clinician might expect in fulminant lobar pneumonia. Yet early modern chroniclers did not always record fevers in a clinical sense. They often described symptoms in terms of humoral imbalance, heat or coldness, or focused on behavior rather than physiologic readings. Plausibility, high as an immediate terminal event, moderate as a sole cause of the long-term picture. Septicemia arising from dental disease is a line of inquiry that draws the medical spotlight to the Queen's mouth. Elizabeth's teeth were often described as darkened and rotten in contemporary letters and ambassadorial dispatches. Dental decay at the time regularly produced abscesses. Left untreated, such infections can allow bacteria to enter the bloodstream, producing systemic infection, sepsis, that impairs multiple organs and leads to collapse. Reports of sores, swelling in the face and mouth, and attendant caregivers' notes that oral complaints accompanied her systemic decline give this hypothesis plausibility. The supportive evidence is the documented poor dental condition and the medical reality that oral infections were a recognized cause of severe illness in the pre-antibiotic era. The weakness of the case is that explicit mentions of the kind of violent fever spikes and delirium commonly associated with classical sepsis are not abundant. Some reports emphasize a slow wasting rather than the stormy course of septic shock. Moreover, sepsis often produces distinct patterns, cool, mottled extremities and rapid heart rate that early chroniclers sometimes might have noted as coldness or waxen color, terms that require interpretive caution. Plausibility, medium to high as a likely proximate mechanism, particularly if a dental abscess coincided with systemic compromise. Lead poisoning from Venetian ceruse, the white lead makeup that was a cosmetic staple, has captivated both scholarly and popular attention because it links culture to pathology. The mechanism is biologically plausible. Basic lead carbonate, the principal ingredient of ceruse, when applied repeatedly, can be absorbed through the skin, inhaled as dust, and ingested secondarily. Chronic exposure produces a range of neuropsychiatric and systemic symptoms. Clinically, chronic lead toxicity can cause cognitive impairment, tremors, abdominal pain, anemia, renal dysfunction, and the characteristic discoloration of gums, a blue-black line. The suggestive pieces of evidence in Elizabeth's case are the long-term use of heavy white makeup, descriptions of tremors and cognitive dulling later in life, and the blackened appearance of teeth noted by observers. But the hypothesis faces significant challenges. First, the symptom complex of chronic lead disease does not neatly account for the rapid decompensation described in March 1603. Lead toxicity is more typically insidious. Second, many of the upper classes used similar cosmetics for fashion. If ceruse were uniquely lethal, we would expect a clearer pattern of early mortality among the aristocracy. Third, no post-mortem testing is available, so one cannot measure bone lead levels or other biochemical markers. Finally, several of the signs attributed to lead exposure, such as tremors and cognitive change, could also be ascribed to age-related neurodegeneration or other metabolic disorders. Plausibility: medium as a chronic contributory factor, low to medium as a primary cause of death. The smart historical judgment recognizes lead exposure as a plausible chronic burden that may have lowered resistance to acute illness rather than the single agent of demise. Melancholia, the humoral category encompassing deep sorrow, brooding, and an array of psychosomatic symptoms, has a special place in understanding Elizabeth's final months. Tudor medicine viewed melancholia as an imbalance that implicated both mind and body. Modern readers might map the term onto major depressive disorder, complicated grief, or prolonged bereavement. Contemporary testimony, courtier memoirs, letters from ladies of the household, and ambassadorial observation recorded behavioral alterations consistent with this diagnosis: refusal of food, sleeplessness, apathy toward public pleasures, and a withdrawal from former patterns of sociability. The execution of Robert Devereux remained a psychological wound that contemporaries repeatedly cited as a source of the Queen's lasting disturbance. From a modern perspective, depression or complicated grief can produce loss of appetite, sleep disturbance, and motivational collapse, factors that materially increase susceptibility to infectious disease and that worsen recovery. The Queen's refusal to accept medical interventions, if faithfully reported, would have compounded the effect. The main challenge is terminological. Melancholia is not, in the strict modern sense, a pathogen. It is a psychiatric or psychosomatic state that mediates risk. Plausibility: high as a significant contributory factor that shaped behavior and resilience. Other proposed medical possibilities have circulated in scholarship, though with less general acceptance. Some historians and physicians have suggested cerebrovascular events, strokes, particularly given reports of tremors, unilateral weakness in certain accounts, or sudden lapses in speech. Stroke is plausible in elderly patients, can produce rapid functional decline, and may be precipitated by hypertension or vascular disease. But the documentary evidence for a focal neurologic event in Elizabeth's last days is thin. Similarly, suggestions of chronic kidney disease or endocrine disorders, such as hypothyroidism, have been mooted, as these can produce fatigue, weight loss, and cognitive changes. Each of these has some phenomenological overlap with the recorded symptoms, but none comes with the corroborating detail one would require to elevate it beyond speculative interest. For these, plausibility ranges from low to medium depending on which symptom set one emphasizes. When historians weigh the competing evidence, a pattern emerges. Age and melancholia lowered the Queen's physiological and psychological buffers. Chronic exposures, cosmetic lead among them, may have acted as a slowly accumulating toxic load. Chronic dental disease provided a potential portal for systemic infection. And finally, an acute respiratory or infective process delivered the decisive blow. This braided, multi-causal model is attractive because it integrates the temporal shape of the illness, years of decline culminating in a short terminal episode, while remaining faithful to the fragmentary nature of the evidence. But to linger on the medical threads alone risks divorcing the body from the political life that, in Elizabeth's case, was inseparable. The Queen's decline unfolded within a spiderweb of decision-making in which fate, calculation, and contingency intermixed. The absence of an officially declared heir had been, for decades, the political skeleton in the court's closet. Elizabeth had refused to name a successor, a choice explained by both pragmatic and psychological motives. Naming one man would have immediately enfranchised a faction and perhaps shortened her own authority. Not naming anyone kept the crown powerfully personal. In the vacuum that followed, Robert Cecil emerged as the man to translate vulnerability into order. Cecil's methods were deft and sometimes clinical. He cultivated correspondence in Scotland and in various English counties. He ensured that key officers, military leaders, sheriffs, and governors received instructions to preserve peace. And, crucially, he worked quietly to place James VI of Scotland in a position to be accepted by the English political class. Cecil's practice of secrecy, his mastery of patronage, and his institutional position allowed him to shape the mechanics of succession without the disruption that an open bidding for the throne might have precipitated. His behavior after the Queen's death, swift proclamations, careful paperwork, and the solicitous treatment of James's envoys suggests a long view. Historians credit his stewardship with helping to avert what might otherwise have been a contested and potentially violent succession. The personal element in these political maneuvers is instructive. Many courtiers had long preferred an English candidate. Others saw advantage in an incoming Scottish king. For James, the prospect of inheriting the English crown had been cultivated through diplomatic marriages, quiet promises, and the art of patient claim-making. Messages were exchanged, emissaries were dispatched, and when the Queen's end came, the speed with which letters and horses moved southward testified to the importance of momentum. Sir Robert Carey, a courtier with the right combination of ambition and opportunity, famously made the rapid ride to Scotland to inform James, an act that historians have alternately criticized and romanticized, but which, in any event, highlights how the mechanical act of relaying information mattered profoundly. The Privy Council's immediate actions after Elizabeth's death were meant to forestall confusion. They secured the royal jewels and records, had proclamations prepared, and sent out formal notice to officials. That the transition proceeded with so little large-scale violence owes much to the councillors' ability, especially Cecil's, to marshal loyal forces and to frame succession in legal and ceremonial forms that the political class could accept. The smoothness of the handover should not be overstated. There were tensions and resentments that would simmer under James's early rule. Nonetheless, compared to many transitions in European history, the Tudor-to-Stuart transfer was remarkably stable, an outcome partly engineered in the days between death and coronation. While ministers took pragmatic steps, the public rituals of mourning and memory began to shape a narrative. The lying in state and funeral ceremonies were not only expressions of grief, but acts of political theater. The Queen's body, dressed and displayed, became an object of both private devotion and public signification. The creation of a wax effigy, a common funerary practice for monarchs, allowed subjects to view a perfected, calm version of their sovereign, one not subject to the ravages of disease. Such effigies performed the work of reconciling the Queen's human end with the continuity of the monarchy, a fixed, almost idealized image that could be publicly mourned. The funeral procession to Westminster Abbey was long and elaborate, as befits the burial of a monarch who had spent 4 decades on the throne. Crowds lined the routes, banners and heralds performed the language of lineage. The effigy conveyed an untroubled face to those who paid their respects. The Queen's tomb in the Abbey was set beside that of Mary I, an intentional architectural and symbolic placement that sealed the Tudor pair in stone. The juxtaposition of Elizabeth and Mary, 2 sisters whose reigns had so differently shaped the nation, became itself an image through which later generations would understand the Tudor age, a closing of a chapter and the memorialization of a dynasty. The memorial practices did not, however, close debate. In the years and centuries that followed, the question of what exactly had finished Elizabeth, the proximate cause of death, kept returning in letters, biographies, and new medical readings. Early memoirists and courtiers framed the death in moral and poetic terms. The grief for Essex, the toll of a life performed in the public glare, and the melancholy of a sovereign who had been compelled to sacrifice intimacy for policy. Later theatrical and literary figures folded her passing into a mythology that emphasized tragedy and stoic romance. The tension between image and reality took on its own life in the arts. The mask that had protected sovereignty in life, now, in death, revealed a story that demanded interpretation. Modern historians have approached the question with methodological caution. Biographers such as Antonia Fraser and Alison Weir have tried to balance the personal and political narratives, while scholars of Tudor medical history, sometimes working with forensic physicians, have sought to align symptoms with pathologies. The lead poisoning hypothesis was popularized in part because it offers a clear, tangible culprit that links cultural practice to bodily harm, but its evidentiary basis remains circumstantial. Those favoring a pneumonia or septic death point to the pattern of acute decline in March 1603 and to the documented conditions that would have made such infections likely. Political historians, for their part, focus less on cause than on consequence, on how the Queen's silence and the absence of a named heir shaped the actions of men like Cecil. The historian's task is necessarily humble here. The sources, while numerous, are often second-hand, partial, or written with purposes other than clinical accuracy. Ambassadorial reports sometimes exaggerated to influence foreign courts. Family letters could sentimentalize, and later memoirs reshaped memories to serve personal legacies. Where multiple independent accounts converge on the facts of appetite loss, sleep disturbance, chronic cough, and dental decay, the convergence commands respect. Where testimony diverges on precise timings, the presence of high fevers, or the extent of visible swelling, we find the limits of inference. Yet, even within these limits, certain certainties can be argued with confidence. Elizabeth's death was not the sudden strike of a spectacular act. It was the culmination of a long process in which age, psychosocial stress, chronic bodily burdens, and an acute terminal insult combined. Her public persona, a carefully constructed image mediated by wigs, makeup, and ritual, had long masked private vulnerabilities. In the end, the image could no longer be sustained. The final pages of her life read like a series of small erosions. Less sleep, less food, a hand's tremor here, a cough there, a retreat from performance, a melancholy that grew into physical frailty. When the last infection or cardiac or pulmonary event came, there was little reserve left to withstand it. There are humane dimensions to this medical historical portrait that bear emphasizing. The language of speculation risks reducing a complex human life to a clinico-pathologic record. Elizabeth was not merely a laboratory specimen. She was a person who had ruled, who had loved and lost, who had performed power and cultivated isolation as a political necessity. The Queen's attendants, women and men who served with fierce loyalty, reported both devotion and grief. Their testimonies, recorded in household books and in letters, preserve a texture of intimacy. Small acts of care, the rubbing of a brow, the offering of warmed broth refused. These details, though unhelpful in clinching a medical diagnosis, are crucial to remembering that the death of a sovereign is also the death of a human being, whose body and mind were subject to the ordinary betrayals of age. The political aftershocks of her death unfolded fast. Within days, James VI of Scotland was acknowledged as king by an English council that had prepared the legal and ceremonial instruments of succession. The manner in which the transfer occurred, quiet, procedural, and supported by the machinery Cecil had assembled, limited the potential for violent contestation. Yet the new king's accession was not merely an administrative footnote. It inaugurated a dynasty that would reshape relations across the British Isles and beyond. The symbolic weight of the Tudor interment, Elizabeth laid to rest beside Mary, was a deliberate act of closure, a finalizing of a particular national narrative. Over the long arc of history, Elizabeth's death served as both a hinge and a mirror. It hinged two dynasties together, and it mirrored the limits of sovereign embodiment. A crown that had for years been a projection of national identity was rooted, in the end, in a mortal frame that could fail. The fascination with the precise cause of death is understandable because it promises clarity where sources are fragmentary. It promises an answer to a curiosity that reaches across 4 centuries. But the fullness of what happened at Elizabeth I's death resists singular reduction. A more honest, and historically more defensible, posture recognizes complexity, multiple factors interacting in ways we can plausibly trace but cannot definitively reassemble. To close, consider one emblematic image, the wax effigy made for the funeral. It is at once a cosmetic restoration and a kind of denial, a perfect, unmoving face that erases the cracks of illness. That effigy performed an important cultural work. It allowed a nation to mourn in the image of continuous sovereignty, while privately acknowledging, in the hush of palace rooms and the scrawl of letters, the quiet human truth of decay. The effigy left behind a question we still ask. How do we reconcile the public brilliance of a reign with the private vulnerabilities that end it? In the final analysis, what really happened at Elizabeth I's death can be best stated as a conjunction. A long-lived sovereign, whose political life was a sustained performance of authority, whose private life had suffered profound losses, whose body carried the injuries of age and chronic exposure, and who succumbed, probably, to an acute infective event or systemic collapse precipitated by those cumulative factors. That conclusion keeps the different kinds of evidence in their proper relation: emotional testimony, household record, ambassadorial dispatch, and medical plausibility. It refuses the false comfort of a single neat cause, and instead accepts the historical truth that human ending is often braided. If you have a theory, was it pneumonia, sepsis from dental disease, chronic poisoning, or the cruelty of melancholia, I'd love to read it in the comments below. For those who want to dig deeper, check the description for a list of primary sources and modern biographies and medical studies that informed this narrative. The last image to carry with you is quiet and paradoxical. A face powdered for performance, laid to rest beside a sister queen, while outside the abbey a new name was added to the roll of monarchs. The era she had shaped did not end with a single cause, but with a silence that was both medical and symbolic, and that silence has echoed through history ever since.